Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a gynecological emergency which came to our ER. Can you start?
Obstetric emergency.
Okay, obstetric emergency. A 32-year-old pregnant lady was referred from outside hospital to our ED. So we didn't get much history, so we suddenly went to the initial 10-second assessment. Patient was a bit drowsy but oriented and was obeying commands. Her airway was patent, there was no pooling of secretions or gurgling or hoarseness of voice. Breathing, her respiratory rate was 18 per minute with air saturation of 98% in room air. Air entry was bilaterally equal. Circulation, her heart rate was 86 per minute with a blood pressure of 150 over 104 millimeters of mercury with a map of 190. And all peripheral pulses were felt equally and bilaterally. Disability, her GCS was E3 V5 M6 and pupils were 2.5 millimeter bilaterally equal reactive. Temperature was 98 degree Fahrenheit and her GRBS was 108 milligram per deciliter, and hypothermia was prevented by blanket. So at present there was no life-threatening injuries, life-threatening features or anything. She was kept on a left lateral position. Only thing was her blood pressure was slightly on the higher side, 150 over 104 was there.
Age?
32-year-old female, pregnant lady. Primary. She was on some medications from outside, so we suddenly went into the sample history of what exactly happened for this female. So
initially you got a history, like pregnant lady coming to you with, what was the history like?
History is
why she came to emergency room?
She was referred from for a gynecologist for a further intervention and emergency delivery, like
okay.
That was a history.
Okay.
So
she never had any other presenting complaints?
Complaints was not there. So we went to the bystanders to get the history. She's a 32-year-old female, married since 12 years. Her obstetric score is G3P2L2, no abortions. First child is 9 years old.
It's not a primary then?
No.
Okay.
First child is 9-year-old and second child is 3-year-old, and this was a spontaneous conception. LMP was on October 10th and expected date of delivery is on 17th July. Presently her gestational age is 30 weeks and 5 days, and according to the last
Previous obstetric history.
Previously, previous obstetric history, she has two sons, 9-year-old and 6-year-old. Both were full-term normal delivery without any complications, no gestational hypertension or diabetes was there. This time also her antenatal history was totally uneventful, and her scans were also normal. Her blood pressure checking was normal, and GCT done at 24 weeks also was normal. Always her BP was also in the normal range. She had took her 2 doses of tetanus toxoid in 3 months and 4 months. And last scan was done 2 weeks back, which was showing a fetal maturity of 9 weeks and 2 days with
29 weeks.
29 weeks and 2 days and vertex presentation. And no other allergies, no other past medical or surgical history. She is on folic acid, iron and calcium. Last meal was 8 hours back. Events is that day she had a headache at home, and blood pressure was checked at home and it was found to be elevated. So she was taken to an outside hospital, and there is no documented history what her BP was. But since her BP was high, they've given her 20 milligram of lebetalol, and still they found her BP is high, and within that time she had one episode of seizures, generalized tonic-clonic seizures lasting for 5 minutes with uprolling of eyes and frothing from mouth. So they written documented that they gave lorazepam and Levipil for that, and they gave 5 grams of MGSO4 IV, and they started on magnesium sulfate infusion and referred here for further management. So that was a history of the patient. So So we are expecting an eclampsia for this patient. So suddenly we kept her. She was already on the left lateral position. 2 large bore IV cannulas were inserted and samples were taken. Samples for CBC for the platelet workups. Then RFT should be checked because elevated creatinine itself will be seen in severe preeclampsias. Then coagulation workups were also taken because we have to rule out HELP syndrome and all. Then blood group and cross matching, pre-op investigations, and LFT and RFTs and electrolytes also were taken. Even the magnesium level also should be checked. Baseline magnesium level also should be checked. And when she came to her ER, the BP was 150, 104. So
investigation pertaining to bleeding.
Coagulopathy work.
So what are the investigations?
We have to look in the CBC platelet will be coming, and we have to check for the PT, INR, APTT values. Then anyway, D-dimer will be elevated in pregnancy. These things should be checked. Then magnesium sulfate infusion we are continuing, 2 gram per hour infusion we are continuing, and labetalol 20 mg IV stat was given for her.
They have already started magnesium or we are starting?
Magnesium only IM injection was given, and they have started an IV infusion was also started.
So on magnesium, what will be the next thing that you need to check? The patient is on magnesium.
Then we have to check for the deep tendon reflexes. We have to check her urine output and respiratory rate.
Respiratory status.
We have to rule out any features of magnesium toxicity.
Okay. Blood gas?
Blood gas analysis was taken. Venous blood gas analysis was taken.
You wanted a blood gas, venous or an arterial?
At present anyway her saturation is normal.
Everything was fine. Okay.
We want to look for any type 2 respiratory failure is there or not, or and postically lactate also can be elevated. But in her ABG was showing normal blood gas status only. Then we have involved the gynec team. Obstetric consultation was done, and we have asked them to arrange a CTG monitor for the child. And at the same time we are expecting another seizure to happen, so we should arrange the oxygen, the crash cart, the airway equipments, and also magnesium and the other anti-epileptic drugs. And we should also give her steroids because she's only 30 weeks. So if at all we are and she has a seizure, so eclampsia, early termination of the pregnancy is a treatment of choice. So for fetal lung maturity we have to give betamethasone 12 mg stat was given, and if at all possible we had to repeat after 24 hours. That was also given. Then a neonatologist was also involved, and NICU bed was also arranged, and we should also arrange calcium gluconate because if at all the patient is going for magnesium toxicity, that also should be arranged.
So right now, what is your diagnosis?
Right now we have a pregnant 30-week pregnant lady with a new onset of seizures and high blood pressure. So it is looks
preceding seizure or hypertension?
Hypertension was preceding seizures.
Chronological order. Okay.
So and her BP was elevated, so it can be a preeclampsia which went into undiagnosed severe preeclampsia which went into an eclampsia.
Okay.
Was she having any regular antenatal checkup?
Yes sir, she was getting a regular antenatal checkup from outside hospital.
So what will be the other investigation? Urine protein?
Urine protein should be sent. Urine protein value came around 310, and urine protein creat ratio also should be checked. Ideally it should be more than 0.3. This patient it came as 2.83. It was elevated.
Supposedly there is no proteinuria. So what will be your diagnosis?
Without proteinuria also if other systems are involved, still we can call it as preeclampsia, or if at all there is no end organ damage or any features, only elevated blood pressure, it will be gestational hypertension. Depending on the time when we diagnose it as high blood pressure. If at all the patient is having a high blood pressure even before 20 weeks, or if high blood pressure is diagnosed after 12 weeks of postpartum, then that will be chronic hypertension. And if the female is having a elevated high blood pressure means BP reading more than 140/90, that is checked twice, at least with a 4-hour gap.
4 to 6 hours apart.
Gap. And that is diagnosed after 20 weeks, then it will be called as gestational hypertension. And if there is some features of end-organ damage or proteinuria and all, we call it as preeclampsia. And severe preeclampsia means the blood pressure will be more than 160/110 with features of pulmonary or elevated creatinine, that means creatinine more than 1.1 or platelet less than 1 lakh, or features of headache, epigastric pain, reduced vision, these features also will be there. So these patients can go into an eclampsia, they are having high risk for eclampsia.
What?
LFT was ordered.
This patient's LFT was on the normal side, sir. Bilirubin was 0.09 and direct was 0.04. OTPTs were 24.2 and 11.8. In if liver involvement disorder and HELP syndrome and all, bilirubin will be more than 5 and OTPTs will be more than twice that of the normal value.
Suppose what will be your other differentials rather than your preeclampsia, eclampsia? Can they present with something else, these patients?
Pregnant ladies with seizures, we have to think of other DDs, like it can be some toxicological causes or some stroke or IC bleed, cerebral venous thrombosis, CVT, then meningoencephalitis. These things also should be considered.
Suppose there is no seizure, only visual abnormalities. What will be your differential that you will keep in your mind?
High BP
Press should be ruled.
Press syndrome, again, pregnancy is one of the commonest thing that you can have, press syndrome. Can you just elaborate press?
Press is posterior reversible encephalopathy
Syndrome, they will present with, usually it will affect the occipital
region, reduced vision, and seizures can be there.
Seizures can be there. So again, that is one of your differential that you need to keep in your mind. The management difference will be hypertension management. Hypertension control is the management in press syndrome. But if it is eclampsia, preeclampsia, your treatment option will be magnesium sulfate. So now can you just elaborate from, for example, a patient is she has become pregnant. From the day onwards, what all problems that you can have in the blood pressure? So can different nomenclature for the clarity.
Usually in pregnancy, what is happening is there will be a drop in blood pressure initially. Towards after 20 weeks only the BP might become normal. So initially there will be a drop in blood pressure, maybe because of supine hypotension, because the IVC is getting compressed by the uterus and all.
When
so
the IVC will be getting compressed by the uterus?
That is usually after 20 weeks. So
not in the early stage.
So usually they will be having somewhat a physiological hypotension will be there, sir. Then after that, after in the third trimester and all, they will be having a normal blood pressure.
So suppose this patient is already having hypertension. So can they get precipitate into a preeclampsia or eclampsia?
Yes, sir. If the blood pressure control was not adequate and all, they can go into a new onset proteinuria or end organ damage.
So that will be called chronic hypertension, because already there is hypertension, they became pregnant and now they are going into preeclampsia. So then you have gestational hypertension, as you mentioned, after 20 weeks. Then you have the preeclampsia and eclampsia. Sometimes they just present like this. They come with preeclampsia or eclampsia. So these are the different things that you need to understand. Usually eclampsia, when it will subside?
Eclampsia usually after 1 week of within 1 week, if the postpartum, if the patient is having seizure, that also should be considered as eclampsia. After 1 week, it is very unlikely to have a seizure because of the eclampsia.
Okay. Gestational hypertension?
Gestational hypertension after postpartum 12 weeks, if the patient is having elevated blood pressure, that is chronic hypertension. Before 12 weeks, it is called gestational hypertension.
So these are the different terminologies, so you should not get confused by this. So now we'll go to this patient again. Now this patient has come to the emergency room. You have started magnesium sulfate. So what are the options in starting magnesium sulfate? what are the different regimens?
We have to give a loading dose and also a maintenance dose. So loading dose, either we can give as intramuscular or IV loading dose can be given. So intramuscular we can give 4 to 6 gram intramuscularly. 4 to 6 gram IV can be given over 15 to 20 minutes, or intramuscularly we can give 5 grams in each buttocks as a stat dose. So total 10 grams. Then we have to give the maintenance dose. So we have to give it as 2 gram per hour infusion over 24 hours for the 24 hours, and then we can give as Pritchard regimen. That means we will be giving intramuscular injection as 5 grams in each buttocks 4th hourly. So each time we have to check for the plantar reflex, the respiratory rate, and also the urine output. And if at all the patient is having an elevated creatinine, we have to adjust the dose accordingly. Suppose if the patient is having a creat value between 1 and 1.5 with very good urine output, we can reduce the dose of the magnesium sulfate to half IV infusion, and we have to monitor the magnesium level every 6th hourly. If at all the patient's creat is more than 1.5 and if the urine output is becoming less than 20 ml per hour and all, we should stop the magnesium sulfate infusion.
Okay. So that are the different regimens. So now you have started on magnesium sulfate. Still the patient is developing seizure. So what will you do next?
So if the patient is getting the magnesium sulfate infusion and if still seizure is there, we can give one more bolus dose. That is 5 grams IV bolus can be given, sir. And if at all the patient is again having seizures, then we have to involve a neurologist, and we can start on phenytoin. Phenytoin 1.25 gram should be given, and that should be given as 50 mg per minute IV infusion should be started. And this time we have to plan on an intubation also.
Okay. So airway compromise. Role of anti-epileptics comes only as the maybe a second line or third line agents only. So first line it is magnesium sulfate. Maybe first line what we can see is termination of pregnancy. That is the first thing that you need to keep in your mind. Termination of pregnancy. Before that you can give your magnesium sulfate, bolus of magnesium sulfate again. Then comes phenytoin and other antiepileptics, and maybe a sedation and paralysis. So that will be the agents that you need to remember. So in airway management.
Regarding the planning for RSA, what are the situations you will be anticipating? For an intubation?
This is a pregnant lady. So pregnant lady, again the supine hypertension problem will be there. So whenever we are positioning the patient for intubation itself, we have to give a manual displacement of the uterus. And in the airway itself, there can be airway edema, enlarged face, and the soft tissues will be swollen. And the chest rise cannot be seen properly in females because of the enlarged abdomen and all. Their functional residual volume will be low. While ambuving itself, the patient can go for aerophagy because of the lax sphincters and all. Residual, they cannot tolerate much of hypoxia because functional residual volume is low. Apnea time also should be reduced. Then in patients with associated coagulopathy and all, there is bleeding risk. While scoping, and there is bleeding risk. And aspiration also is.
Okay. So
what other things? You are already administering so many drugs. So you have to keep in mind that the interaction.
Yes, sir. Drug interaction.
Which drug will interact with magnesium sulfate? With the RSA. Muscle relaxants. Okay. Especially non-depolarizing muscle relaxants. Better to avoid them because they will be prolonged duration of action. Choline is the best option. Or if you have to use in a smaller doses, incremental doses, we can go for that. And magnesium sulfate itself may be causing respiratory depression and then need for an intubation. Okay.
Then again,
what else you have to keep in mind is fetal monitoring. So fetal monitoring and the control of the BP.
Yes, sir.
See what are the steps you will take controlling the BP?
This patient was getting a labetalol stat doses, and if at all the blood pressure, our target blood pressure in case of an eclampsia patient is systolic between 130 to 150 and diastolic between 80 to 90. That range it should be maintained. If at all we are giving labetalol as a stat dose, we have to repeat every 5 to 10 minutes, and we can increase the dose as 40 to maximum 80 mg IV stat can be given, or we can give it as 1 to 2 milligram per minute infusion can be given, sir.
Suppose the patient BP is 210 by 130. How will you bring down the BP and at what level? You
Target.
bring down, how fast you
The thing is, in eclampsia and preeclampsia, we can reduce the blood pressure more than 25% within 1 hour itself. So our target, as we already mentioned, so we can give a larger doses of labetalol and we can reduce the blood
So
pressure.
suddenly if you are lowering the BP, what will happen?
Perfusion, end organ perfusion will be affected, and the euplacental perfusion also will be affected.
See, let us slowly bring it down, and up to 160 systolic and less than, slightly less than, that is better, and also diastolic less than 110. Don't suddenly bring it here now. So fetal monitoring should be ongoing all through that. So you have to keep in mind about during the intervention any other precaution. Suddenly BP very high, so you have to avoid all the stress response.
Yes, sir.
Sometimes how will you avoid the stress response?
Adequate sedation and adequate analgesia should
So
be
what will
given.
you prefer here?
We can give fentanyl can be given for analgesia, and induction agent we can select anti-seizure activity. Propofol is having anti-seizure activity, so propofol can be started, and etomidate also can be started. Propofol is having will reduce the blood pressure also. So if at all she is having a very high blood pressure, we can prefer propofol. Then etomidate, if the BP is normal, etomidate will not affect the blood pressure. We can avoid ketamine because it will increase the blood pressure. Then paralytic agents also, if at all we are planning for an emergency cesarean, we should avoid the fetal floppiness of the child. So ideally rocuronium and all is not advised because that can cause floppiness. So trachurium or cisatrachurium is preferred, but rarely it also will have seizure activity.
So all patients require RSI, or they can go for LSCS with the spinal anesthesia?
Eclampsia,
if there is no seizure activity, you have got better BP control, we can think of even regional. What is your opinion, sir?
During labor, so 2 occasions there will be increased airway edema. One is when the patient is in active labor and during the delivery. So the pronounced airway edema will be there. At times sometimes there may be intubation difficulty will also be there. So first thing, try to bring down the BP to the acceptable norms. Then you can go for avoiding the further stress. So one of the other thing is we can give even a lignocaine, 1.5 milligram, 1 to 1.5 milligram per kg. Pre-treatment we can give. Okay, and
laryngoscopy.
Pre-treatment. Okay, and gentle doing the laryngoscopy and other things. Keep smaller sizes tubes also, because we may be anticipate to putting 8 may not be good. 7.5, 7 also should be readily available. And you have to keep in mind all the other complications which may be precipitated because of high BP. What are the complications where you would add?
There can be maternal and fetal complications. Coming specifically to the fetal complications as such, there can be fetal decelerations, and if there is a deceleration more than 10 to 15 minutes, there can be an abruption of placenta. Sudden infant death can be there.
Fetal monitoring
Should be there. And then fetal immaturity will be, since this patient and all came in 30 weeks, so immaturity can be there. Then there is risk of other coagulopathies, DIC risk is also there. Then maternal risk factors, same coagulopathy induced risk factors are there. Then elevated blood pressure itself can cause IC bleed and IC bleed.
All systems.
Systemic.
So, IC bleed on cardiac,
Pulmonary edema.
renal, and pulmonary edema. These are things, and Fluid management. What is the fluid management for these patients? What fluid you select? How much you will be?
Fluid management, crystalloids can be chosen, sir, and
Don't give
overload.
Nitrogenic fluid overload, pulmonary
Edema can sit in.
Because there may be cardiac tension. CCG monitoring is also there. Whenever you are opting for an RSA, in the VTCO2, and you want to monitor for as far as telling, when you are planning for this one, elective, we can go for the regional, that is painless labor, that part. But only thing is any bleeding episodes will be there, we have to rule out how TB. The test will be done to make sure that will not be done. Platelet count is also another baseline, based on which we will be whether select for a regional or a GA. See, if there is a bleeding tendency, sometimes there may be hematoma formation. It may be in the epidural hematoma, so it may compress and may cause the miscarriages. Okay. Option is regional is best. So it itself will be controlling the BP to a certain extent, and it can be started painless labor, analgesia. So it will further increase in the BP will be avoided by this one. Keep in pain. There are two things. We are putting in epidural only to relieve the pain during the labor. Another one is when we are planning for the cesarean section. So the depth needed is very. So the percentage of the solution, local anesthetic solution, we will be selectively blocking the sensory part. So motor part will be still active. So when we are going for the cesarean section, both sensory and motor.
Okay. Any role for aspirin?
Aspirin, gestational hypertension, aspirin, there are many pathophysiologies for this gestational hypertension. They are telling like after 20 weeks there will be a second wave of uterine artery invagination that will be affected in gestational hypertension. So aspirin is usually preferred, and it is usually given in a low
improve the
dosage.
blood flow
to the
placenta
and prevent placental infarction.
Okay. So what was done for this patient?
This patient, magnesium sulfate infusion was given, and she was and continuous CTG monitoring was done, and it was showing fetal decelerations were there, and fetal compromise was distress was shown. So she was taken for an emergency cesarean section was taken, and she delivered a male child, 1.5 kg male child was delivered. Already steroids was also given from the ED itself.
24 hours later or immediately they took her?
Immediately she was taken.
Then this thing, what was the anesthesia, regional or RSL?
She was taken for general anesthesia.
General anesthesia, okay.
If at all, in this patient, since she is having eclampsia, she was taken for immediate delivery. Otherwise, if the patient is having uncontrolled severe preeclampsia, usually after 34 weeks, we are telling that lungs has matured. So after 34 weeks itself, we should terminate the pregnancy.
Immediately after 34 weeks.
Or if the patient is having good blood pressure control and all, we can prolong to 36 to 38 weeks. Then when all to involve a neurologist if at all the patient is having seizures. So if the patient is having seizures even after giving an extra magnesium sulfate dose, we should involve the neurologist. Or if the patient is having any focal neurological deficit other than the postictal state, or prolonged loss of consciousness, or any seizures which is coming less than 20 weeks of gestation.
Okay. We are looking for another CNS causes. Okay.
Postpartum.
Okay, good.
Thank you.